This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, this is Halley Alexander with the Neurology podcast. I'm here today with Luis Alcala-Zermeno, an epileptologist who's now at Columbia University, and we're going to talk today about epilepsy surgery, specifically the outcomes of surgery on tonic-clonic seizures. He recently performed a study on this topic with his colleagues, which is published in Epilepsia. Luis, welcome to the podcast.
Hi, Halley. It's great to be here. Thank you so much for having me.
Yeah, I'm excited for this conversation because, as you know, we have a lot of studies that look at the outcomes of epilepsy surgery. So what's new or different about your study?
As much as I would like to claim some extreme novelty, well, there's really nothing new to the concept of the epilepsy surgery that we're describing. Is just simple, single lobe resection. What changes is how we look at it. So you take a deep dive into the literature and see what has been published specifically with regards to tonic-clonic seizures when it comes to epilepsy surgery. You'll soon figure out that it's mostly a cautionary tale. It's like every single paper tells you if your patients had tonic-clonic seizures at baseline, they're less likely to achieve seizure freedom and so on and so forth, with just a handful of studies really looking at what happens when you have surgery and whether tonic-clonic seizures go down or up, which to me makes a lot of sense because at the end is what drives mortality in our patients.
To summarize what you're saying there is your study is looking at the outcomes on the tonic-clonic seizures, and I'll back up and just explain. Because of our ever-changing nomenclature, tonic-clonic seizures we're talking about, they've also been called focal to bilateral tonic-clonic or secondary generalized tonic-clonic. Older terms would include grand mal or even convulsions. So we're talking about those big seizure types. And so you're looking at the outcomes for those. How would that compare to what we normally think of as the outcomes from epilepsy surgery, such as the Engel classification for surgery outcomes or the ILAE classification?
So the Engel scale is probably the best known of the outcome classifications for epilepsy surgery. It essentially has 4 big classes, with each of them having between 2 and 4 subclassifications. Most studies try to define the success of epilepsy surgery as those patients who are part of class 1, which is free of disabling seizures. Sometimes they include class 2 there, which is rare disabling seizures. In comparison, the ILAE also has its own classification that involves 6 classes without subclasses, which goes from completely seizure-free to an increase in seizure frequency. However, none of these classifications address tonic-clonic seizures directly, which is a big part of what we see in patients with drug-resistant epilepsy. I mean, there's estimates from the Cleveland Clinic that up to half of the patients that we evaluate for epilepsy surgery have tonic-clonic seizures, which it's a problem because at the end, we're not trying to just make people seizure-free. Sure, that is the holy grail of epilepsy surgery and the bar that we set up for ourselves. But we also need to acknowledge that reducing mortality is a big part of what we need to do as a community.
Yeah, that makes perfect sense, especially because these tonic-clonic seizures are the ones that are the most associated with mortality related to seizures. So I'm glad you did this study. Can you tell us now, what did you find?
I did this study when I was completing my fellowship at Thomas Jefferson, and there's a big surgical database there that has recorded the outcomes of patients undergoing surgery from 1986 onwards. And what we did was essentially look at all the patients who had a single lobe resection to try and really narrow down the exposure, narrow down the procedure, and make it more applicable for the readers and the community that reads this, and see what happens with regards to tonic-clonic seizure frequency if they had tonic-clonic seizures preoperatively. We also looked at seizure freedom. And finally, we also looked at one question that comes often in the clinic, which is patients who may ask you, well, is there a chance that surgery is going to make my seizures worse? So for that, we looked at the development of de novo tonic-clonic seizures, meaning patients with clear documentation of never ever having a tonic-clonic seizure before surgery who developed them afterwards. And what we found is that of a total of 804 patients, of which 531 had tonic-clonic seizures at baseline, after they had surgery, 58 were free of tonic-clonic seizures for the entirety of the follow-up period. It was a median of 7 years. And in that category, 33% of them were completely seizure-free after surgery. So of the 283 patients who did not have tonic-clonic seizures preoperatively, 17 of them developed de novo tonic-clonic seizures. That's a 6% of that subcohort. However, of those 17, only 3 of them had ongoing tonic-clonic seizures after the follow-up, meaning more than 10 during the recorded follow-up period. Now, the good part is that 47% of those patients, meaning the patients who did not have preoperative tonic-clonic seizures, were completely seizure-free after surgery.
Excellent. Thanks for explaining that. So these are exciting findings. I'm going to kind of summarize and clarify one point. So if the patients that did have tonic-clonic seizures prior to surgery, 58% of them became free of tonic-clonic seizures after surgery. Is that correct?
That is correct. It means they never, ever had a convulsion after the surgery took place and during the entirety of their follow-up period.
Excellent. And then of the people who did not have tonic-clonic seizures prior to surgery, or at least there was no evidence of that, a small percentage, 6%, developed some afterwards. And then an even smaller percentage of those actually continued to have the tonic-clonic seizures.
Yes, it was mostly less than 10 seizures during the follow-up period. Those patients still derived benefit from the surgery.
Yes. And it also reflects what you said. We already know from the literature that the people who did not have tonic-clonic seizures prior to surgery, they had 47% seizure freedom compared to those that did had 33% complete seizure freedom of all seizure types. Is that correct?
Exactly.
Okay. Were there any limitations to your study? How should we best interpret this in clinical practice? For example, I know you did not exclude patients who had laser ablation, which is a common practice at some centers now. So can you talk some about any other limitations?
Well, designing the study, that was a big back and forth. Dr. Sperling and Dr. Ramozzi, my co-authors. At the end, we decided not to include patients who had undergone laser ablation just because during the time period that we use, there was only a handful of them, and that would have essentially changed the type of surgery and the applicability of the results in bulk. I do think that a similar study needs to be conducted once we have more patients who have had laser ablation. And it would be nice because one of the arguments that sometimes counter proposing laser ablation, specifically mesial temporal lobe laser ablation versus a standard temporal lobectomy, is the presence of tonic-clonic seizures. We know that that was one of the things that really increased the seizure freedom yield after a standard temporal lobectomy when compared to mesial temporal laser ablation. Other limitations that we had for this study is, well, it's all one center. So at the end is the tradition of the physicians that have been there for years and how they're used to see patients with drug-resistant epilepsy. We know that although there are guidelines that try to be clear on when to refer and when to do surgery, there's a lot of variability out there. And finally, and probably the most important limitation, is that the vast majority of patients, over 90% of the patients that we're talking about in this study, were temporal lobe patients. Most of them mesial temporal lobe epilepsy, but some of them having neocortical temporal lobe epilepsy, which does limit the applicability of the results to other neocortical epilepsies that you can see frequently, such as frontal lobe epilepsy.
Thanks for explaining that. And we actually did do a podcast a while back about the variability of epilepsy surgery at different centers across the U.S. So we'll try to link that in the show notes as well. Now, as we know, epilepsy surgery referrals are vastly underutilized. People are not getting referred for epilepsy surgery in a timely manner. It's often delayed several years. So to review, the guideline is that any patient who's failed at least 2 properly chosen and adequately dosed anti-seizure medication should be referred for consideration of epilepsy surgery. That seems pretty straightforward on paper. So why do you think patients maybe aren't getting referred?
That's the $1,000,000 question. It's so variable because we need to consider, first of all, who's referring them. There's a lot of variability in how referrals to level 4 epilepsy centers get their pre-surgical patients. There are health systems that are highly coordinated where every single clinic belongs to the same health system. So there's much more likelihood of a primary care provider talking to a general neurologist and the general neurologist talking to an epileptologist. But that's just a minority of the cases. Most of the cases, we have disjointed healthcare systems that may not be willing to share the patient, essentially. There's an understandable fear of losing patients when you refer them to epilepsy center, although that's never been our intention. Patients who come to a level 4 epilepsy center referred by a general neurologist should have as a goal to go back to that general neurologist once epilepsy surgery candidacy has been assessed, and if they go through surgery, they need to be followed by their neurologist. So the whole referral network is flawed to an extent. And then that's one piece of the puzzle. The other piece is that even within the center, within level 4 epilepsy centers, there's variability in how physicians consider whether patients should be referred or not. There are certain situations where, despite failing 2 drugs, or to be honest, it's almost never 2 drugs. It's at least 4 or 5 from my experience. And in those cases, there are certain characteristics such as age or etiology or underlying psychiatric conditions that may make the epileptologist from a given center less likely to present patients in the epilepsy surgery conference where candidacy is ultimately decided.
I agree. There's a lot of nuance there. So let's talk about some of those reasons, maybe with a couple of cases here. So say we have a 25-year-old male who has a pretty explosive onset of seizures, maybe did achieve brief control for a while, but then becomes uncontrolled. So he's failed several anti-seizure medications, including Trileptal, Keppra, Depakote, Xcopri, Aptium, and he has significant concurrent anxiety that does limit his care. An autoimmune etiology is suspected, but no antibody is found. Let's talk about the nuance of that case. Should that patient be presented at epilepsy surgery?
That's a tough situation. I think that, and probably a lot of places, the 2 limiting factors that would decide whether that patient gets presented or not is, 1, has the patient received immunotherapy if there's suspicion of autoimmune epilepsy? And if they have had any evidence of or biomarkers of inflammation gone down and seizures continued. So, for example, if this patient were to receive, let's just say, IVIG and steroids empirically, and his seizure frequency went down, I mean, the argument would be, okay, we can try to continue with ongoing immunotherapy. However, if you told me this patient already received all of the immunotherapy he could tolerate, and the lumbar puncture is non-inflammatory, there's no evidence of inflammation on the MRI with contrast, I think that patient needs to be referred. If there is long-lasting damage to the brain, then chronic epilepsy ensues, and at that point, it's just another patient with drug-resistant epilepsy that needs to be evaluated for potential surgery. And there's literature on this. There's at least 2 case series, one encompassing the Mayo Clinic experience. I think they pulled patients from all 3 centers who had concerns for an autoimmune epilepsy etiology and underwent pre-surgical evaluation and eventually had responsive neurostimulators implanted with good response. Of course, you don't reach seizure freedom, but you don't exclude them from that population. Even patients who had autoimmune epilepsy, specifically GAD65-related autoimmune epilepsy, can have temporal lobectomies, and some of them can do well. I mean, this is a paper by Zal Fleming and Kelsey Smith from Mayo in Rochester.
That's a good point. And there is a lot of nuance there. And maybe some folks might not always be considering whether it is still the inflammatory process that's causing the epilepsy and thinking immunomodulation needs to be done, or is the actual inflammatory aspect of it resolved and we're actually dealing with more basically a lesional epilepsy at that point. And what would you say about somebody with a strong concurrent psychiatric issues, be it anxiety or maybe depression?
I think a lot has to do with what's going to be the target of the surgery. If you're going to end up doing any sort of resection or ablation of the mesiotemporal structures, it's not a contraindication. I never see it as a contraindication, but you should strongly consider having a psychiatry colleague on board to try and reduce the anxiety symptoms to a functional level and then proceed with surgery, just to prevent any potential degree of worsening of the underlying psychiatric condition after surgery. For other potential resections, like frontal lobe resections, parietal occipital, even insula, I don't think that we have good data to categorically fear epilepsy surgery in someone with an underlying psychiatric condition.
Agree. And I might argue that sometimes treating the epilepsy and resolving the seizures is a positive treatment for the comorbid psychiatric issues as well. Is there anything else you want to say about your study and this area of research?
Evaluating a patient for potential epilepsy surgery doesn't equate immediately having them undergo surgery. It's always good to keep the options open, be aggressive with referrals to epilepsy centers. There's a lot of good that can come out of that. And the way I see it is there is no tolerable amount of tonic-clonic seizures. But those are the things that can eventually kill our patients, and we need to be aggressive in addressing them. And the best strategy that we have for that when medications are failing is epilepsy surgery. Just think about it. Don't put it in black and white as, success is seizure freedom, failure is everything else. There's degrees of success here, and lowering mortality is pretty successful.
I'm glad you brought that up, because that is another factor that might limit referrals, is actually the patient's perception. And I think it is important to explain to the patient that just undergoing the workup for the surgery is not committing to or agreeing to the surgery. It's doing the workup so that then we can discuss with them the actual risks and benefits for their specific case. And then they can decide with all the information whether they want to pursue it. So I'm glad you mentioned that. So thanks again, Luis, for joining us on the podcast today.
Thank you so much for having me.
For more details, you can find that article. Again, that's published in Epilepsia. And the title is The Effect of Epilepsy Surgery on Tonic-Clonic Seizures.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.